tables above show the doses that are recommended for patient groups for different drugs and different ages. A healthcare provider may offer you different treatment options based on the status of the infection. Prophylactic treatment. If you have a reason to believe you or your child has been exposed to the virus, a healthcare provider might suggest prophylactic treatments to help prevent the infection from taking hold. These treatments include vaccination. Healthcare providers recommend an immediate dose of the hepatitis B vaccine if you haven't had it yet, preferably within 24 hours of exposure. You'll need 2 more doses over the next 6 months to become fully vaccinated against the virus. Hepatitis B immune globulin, HBRG. HBRG is a substance made from human blood containing naturally produced antibodies to the hepatitis B virus. It's given as a shot to help prevent infection in people who've recently been exposed to the virus. These treatments are very effective in preventing babies born to parents with chronic hepatitis B from becoming infected. Infants who receive these treatments shortly after birth have a good prognosis and they can safely breastfeed. Now, for the surveillance for hepatocellular carcinoma (HCC) among people with chronic hepatitis B. Routine surveillance for HCC with abdominal ultrasound and alpha fetoprotein testing every 6 months is recommended for people with cirrhosis regardless of age or other risk factors, people with a family history of HCC. If there is no family history of HCC or evidence of cirrhosis, people older than 40 years old, and with HBV DNA level above 20,000 international unit per ml, if HBV DNA testing is available. When to stop and restart antiviral therapy. Lifelong nucleotide analog therapy is done for all people with cirrhosis based on clinical evidence or APRI or transient elastography score, require lifelong treatment with nucleotide analogs, and should not discontinue antiviral therapy because of the risk of reactivation, which can cause an acute hepatitis flare. For the discontinuation, antiviral therapy is lifelong. Discontinuation of nucleotide analog therapy may be considered exceptionally for people without clinical evidence of cirrhosis or based on a non-invasive test score APRI or transient elastography suggesting advanced fibrosis, and who can be followed carefully after discontinuation and long-term for reactivation, and if there is evidence of hepatitis B E antigen loss and seroconversion to anti-HBe for people initially HBe antigen positive and after completion of at least 1 additional year of treatment, and in association with persistently normal ALT levels and persistently undetectable HBV DNA levels if HBV DNA testing is available. If HBV DNA testing is not available, discontinuing nucleotide analog therapy might be considered for people who have evidence of persistent hepatitis B surface antigen loss and after completion of at least one additional year of treatment, regardless of previous hepatitis B E antigen status. Now for the retreatment. Relapse is common after stopping therapy with nucleotide analogues. Retreatment is recommended if there are consistent signs of reactivation, hepatitis B surface antigen or hepatitis B E antigen becomes positive, ALT levels increase or HBV DNA becomes detectable again, clinical features of decompensated cirrhosis, portal hypertension, ascites, hepatic encephalopathy, coagulopathy, or liver insufficiency, jaundice. Other clinical features of advanced liver disease or cirrhosis may include hepatomegaly, splenomegaly, pruritus, fatigue, arthralgia, Palmer erythema, and edema. The ULN for ALT has been defined as below 30 U per ml for men and boys and below 90 unit per ml for women and girls. Persistently normal or abnormal may be defined as two ALT values below or above the ULN at unspecified intervals during 6 to 12-month period. ALT levels fluctuate with CHP and require longitudinal monitoring to determine the trend.